Session number 2 on universal health coverage and access to healthcare. So we have about 1 hour and a half. I'm the chair of this session. I'm Luigi Siciliani. I'm a professor in health economics at the University of York. So just to briefly tell you how we have organized this time. So about half of the time is going to be on some presentations, and the other half, so we have left quite a lot of time for questions. So while you are listening to the presentation, start to think about your questions. So we're going to start with Martin McKee, who is a member of the expert panel. So he'll give an overview of some of the work that we have done. And he will focus in particular on the challenges that we have faced while writing these opinions, which normally fall under 3 main items. The first item is always like, how do you come up with a conceptual framework that allows you to address a specific question? The second bit is about the evidence. Then you have to look quite quickly for all the evidence that is relevant to inform that conceptual framework. And then the third bit, which is also a very difficult one, is how to formulate some recommendations that make sense. So those are the things that we're going to reflect on through Martin's presentations in relations to these various opinions. We had, so the opinions we're going to focus are the one on access, paying for expensive medicines, vaccinations, and health promotion. So it's quite varied topics. And after that, we are going to have some brief presentations, 5 minutes each, from several speakers who are going to give us some feedback in this area about their experience and their thoughts about how to bridge the gap between evidence and policy. And this will be from stakeholder, from member states and the European Commission. And after that, we are going to open up for questions from the floor. So that's the plan. So we'll start with Martin McKee with the first presentation.
Okay, thank you very much. And the microphone is working. Great. So thank you, Luigi, and thank you all for coming to join us here today. I want to put the work that we are doing in context. Every one of our member states, not just within the European Union, but within the wider UN system, has committed to the Sustainable Development Goals. That's really important. Heads of government, heads of state have committed to these goals. And one of the goals they've committed to is SDG 3.8, or one of the targets, and that's to achieve universal health coverage, including financial risk protection, access to quality, essential healthcare services, and access to safe, effective, quality, and affordable medicines and vaccines for all. That's quite a commitment, because although in Europe we have signed up to these values for many years, and we heard earlier how the National Health Service in the United Kingdom, the Dutch system, and in fact all of our systems guarantee universal health coverage, that's not the case in the rest of the world or even in other high-income countries. So let's keep that at the back of our minds as we go forward with this, because the challenge is how to make this a reality, because even though, as we'll see, we have all signed up to them, we haven't really fully achieved it for all of our vulnerable groups. So our philosophy in the expert panel is that we take a European approach. Yes, we have citizenship of different countries. Many of us have got citizenship of more than one European country, thank God. But we come together as experts from across Europe who happen to live in or have been born in a member state, but we are fundamentally a European panel. We speak as a European panel, we work as a European panel, we take a European perspective. We recognize that the health systems within member states are a product of history or a product of culture, a product of politics, and we respect the autonomy of member states to define the health systems in the way that they do. We do not endorse any particular model. We may have views about which ones do different things in different ways because we know there are trade-offs, but we are not pushing a particular model. And we try to address challenges that are common to everyone. But we recognize that the recommendations that we make will have to be adapted to context. And I'd like to pick up on what Jet and Powell and others were saying earlier. Context is hugely important, and we'll see that come out in a number of the examples that I'll give. So as I said, the problems that we face are that although all member states have in theory and in law endorsed universal health coverage, in reality, there is a persistent unmet need, and especially among certain vulnerable populations. So clearly, measuring need for healthcare, measuring unmet need, was always going to be one of our priorities to look at. And as we also heard earlier from George and from others, vaccine coverage is low. We have highly effective, safe vaccines, and yet we have cases of measles in the European region. This is incredible. And we also know that we have many advances. George, again, you were talking about immunotherapy and antibodies and so on. All of our health systems share the problem of affording some of the more innovative medicines. So these were the sorts of things that were at in our minds as we were moving forward, and obviously in the Commission's minds too, as they reflect the priorities that they hear from the Member States and from elsewhere. So, the opinions that I'll be talking about today in this session, others will be picked up in the later sessions, are our opinions on access to health services in the European Union, on benchmarking access to healthcare in the European Union, measuring and providing a mechanism for monitoring, innovative payment models for high-cost medicines, vaccination programs and health systems in Europe, and fostering health-promoting health systems, getting health promotion into health systems, because fundamentally, if everybody was perfectly healthy, we actually wouldn't need health systems. So that is clearly at the core of many of the things that we do. Others, as I say, will be picking up, Dion will be picking up others later. We heard from Kazim earlier about fact sheets. We produce fact sheets as well, trying to communicate the messages in a simple way, because we know that many of the people we need to reach are busy, and it is probably a challenge to expect them to read a 120-page report, so they don't have to, but we have the report if they choose to do that. So I want to take us through the process and look at some of the issues that have arisen and illustrate them with some examples. A lot of what we do is to struggle with definitions and concepts and conceptual frameworks. We're not in the process of producing telephone directories of lists of issues that might need to be done. We need to put these things into a framework that makes sense and try to capture the totality of the problems that we face so they can be adapted to individual member states, individual professional groups' needs and interests. And the examples I'll use will be looking at vaccination, and looking at conceptualizing unmet need, and challenging the accepted wisdom on medicines pricing. So with vaccinations, we often think of vaccination as the act of a health professional sticking a needle into usually a child or an elderly person for influenza vaccine, or maybe, if they're lucky with polio, putting a bit of liquid onto a sugar cube. But that is only one very, very small element. And if we only focus on that act of sticking a needle into somebody, then we will really miss out the reasons why we are not getting the levels of vaccine uptake that we require. So we need to have health systems that go all the way through, from ensuring vaccine safety, to monitoring outcomes, to supplying the materials to make sure people have the materials for providing vaccines, for evaluating progress, for registering the population. Some member states do not have a list of all the children who need to be vaccinated. And even those that do have a list of most of the children may not include all of them, like homeless children or migrant children or undocumented migrants. So if you don't have a register, how can you know whether you're achieving adequate uptake or not? We need to look at enabling legislation. We look at regulations. We need to look at public attitudes. And often, and we cover a lot in our report on, of course, the anti-vaccine movement, the psychology, the cognitive biases that are involved. But we also know that a lot of the problems in a number of member states are because we don't invest enough in our public health services. And we have clear empirical evidence, at least in 2 member states, that is the case. So vaccines I'll put to one side for a minute. We'll come back to it. I want to say something about access to care. Now, yes, I mean, we're as guilty as everybody else of having definitions that are written by committees. Access is a multidimensional issue, but we recognise that barriers to access are at the levels of individuals, of health services providers, and the health system. We need to look at all of these. Access is affected by public policy beyond the health system, especially fiscal policy. So are people denied access because they cannot afford it, because they're impoverished, because they can't afford the money to get to the facilities that they need? We need to look at social protection and education, employment, transport, because in the financial crisis, some member states cut back on the opening hours and in fact, even the opening of clinics. And if that's the case, can people afford, particularly in rural areas, to get to the facilities? We need to look at transport. We need to look at regional development, particularly because we know that investing in health in deprived regions is in itself a major financial impetus to their development. So the way we looked at this was a whole series of issues, but essentially we boiled it down to affordability, to user experience, and to availability. But within that, there are different bits. Unfortunately, when we did this, we could map this onto the questions that were asked in the EU SILC Survey of Income and Living Conditions database. But we had a clear model that services, if they're going to be accessible, and if unmet need is to be reduced, they need to be affordable. There's no point in having services that are there, but people cannot afford them. We need to have them welcoming. We need to have them so that if you're disabled in a wheelchair, you don't have to go up a flight of steps. We need to have them available. We need to have them open at times when people can get to them if they're working during conventional working hours. And we need to have them available in terms of time, in terms of distance. So all of these factors are important. These are the conceptual models that we were developing, our thinking to develop a framework and not just list a whole lot of issues, but put them together into a coherent framework that we can work with. In paying for innovative medicines, we accept that the existing model does not work, we say, well enough. We could say it doesn't work at all. But there's no agreement on how to replace it. We need to find ways that encourage innovation, but not just innovation for the sake of innovation. There is no point in innovating medicines that nobody needs or nobody can afford. We need innovation that actually works, that matters for patients. And then we break this down into a series of questions. How do we deal with the uncertainty about the value of innovative medicines? A really difficult question. How do we create optimal payment schemes that reward innovation, but also ensure access? Not enough to do one without the other. An industrial strategy divorced from a health strategy gets us absolutely nowhere. So that's just a few examples of the conceptual frameworks, the concepts that we were dealing with, the definitions that we were struggling with. I want to move on to the issue of measurement. Indicators, actionability. I want to talk about whose needs are unmet, who are the disadvantaged populations, and where we get comparable data. The problem that we have throughout all of our work is that the health services research available to us in Europe comes from a small number of countries. Lisa Marie, I probably should have added Finland in here as well. I'm being a bit unfair, but it is basically the UK, the Netherlands, Denmark, Sweden, Finland, Italy, and of course, there is work elsewhere. But it is overwhelmingly dominated by those few countries, which is great because we all like to talk about the NHS in England and so on, but actually, you may not have that problem for much longer, but there are other countries as well. And we need to learn the lessons because context is hugely important here. And we just cannot assume that something that works in one country does not work elsewhere. But also it's a crying shame because many of you come from countries other than these, and you're doing a fantastic job in innovating and implementing new models of care, and we don't know about them. But if you don't tell us about them, if you don't evaluate them, you know, it's a little bit like there's a line in The Hitchhiker's Guide to the Galaxy by Douglas Adams. Whenever the Earth is about to be destroyed and the Vogons who are about to clear away the Earth to make for an interstellar highway say, you know, it's ridiculous. Why didn't you read what we said? And they said, well, you know, we wrote about it, but it was on another planet. Why were you too lazy to look for it? You know, don't just talk among yourselves. We need this information to be coming out there. And that's the challenge that we face. Now, we need data. Because if you go to the United States, you've got federally funded survey programs that give you data on hospitalization, on ambulatory care, on all sorts of things. What do we have? Well, we've got the Survey of Income and Living Conditions in Europe, which tells us about people's self-reported health and whether or not their healthcare needs were met. And it gives us all the contextual variables, socio-demographic variables, and so on. It's great as far as it goes, annual rounds with a rotating panel structure. We've got the Eurobarometer as well. We've got a number of things, but actually very little in health. And in Silk, the samples are small with limited power to undertake analyses within countries. So that is a problem for us. We're lacking the literature from Europe, and we're lacking the data from Europe. But we do what we can. And what we've done is to be as inventive and imaginative as we can. This is one of the graphs we prepared using the EU Silk data from the earlier of our reports. And what it shows is that unmet need for healthcare was actually improving, but then that skidded to a halt in 2010, as did a lot of other health indicators across Europe. Life expectancy in some member states, infant mortality went backwards in some countries like the United Kingdom. So a lot of things changed around 2010 for reasons that we're all familiar with. But look at the gaps between the richest and the poorest, the oldest, the youngest, the employed, the unemployed across Europe and, of course, within member states. Now, why is this not on the front pages of every newspaper? Why is this not a matter that is being discussed by prime ministers everywhere and presidents? But anyway, we're using the data in an imaginative way, but we need a lot more data. Who are the disadvantaged populations? Well, this is where, and to pick up on Pavel's point, I'm not sure if he's still here, but we're talking about quantitative and qualitative data, because our recommendation talked about using the quantitative EU Silk data, but it said that we need a qualitative assessment as well, because the vulnerable groups are different in different member states, depending on social policies and fiscal policies, on ethnic makeup and all sorts of things. You know, we cannot simply say we need to look at disadvantaged ethnic minorities. In the United States, the healthiest population are the Korean Americans. They're not actually disadvantaged in health terms, but the African Americans clearly are. So we need to understand how that varies within and between member states. The health needs of the Roma vary considerably in the countries in which they're a significant minority. And of course, the problem we have is that for many of these groups, they're undocumented and they are, in effect, invisible. So you can see the challenges that we face, but we are working very hard to overcome those in our work. I now want to look at context, at the conditions. What are the enabling factors? What are the hindering factors? What helps a member state do something? What stops a member state doing something? Operating a vaccination program, meeting the needs of some vulnerable groups, and incorporating health promotion. Who can administer a vaccine? There are some member states that still insist on a doctor giving a vaccine. This is, I will be perfectly frank, ridiculous. Some countries still, as I say, they insist they do. Now, we looked at that in our vaccination report, and then we linked that because we tried to make our reports coherent, and we talked about that in our report on task shifting, which you'll hear more about later, where we looked at the evidence that, frankly, that is not the case. And then context. Is there an accurate population register? And do those administering vaccines have access to it? Or are there data protection regulations that are in place that prevent people from knowing who should be invited to have a vaccine? When tackling unmet need, many countries within Europe, member states, have very differing attitudes to migration, as you all know. The word willkommen culture does not translate very well into English, unfortunately, and this is the United Kingdom's approach to the hostile environment. Some governments are explicitly restricting access to healthcare as a means to deter migration. They are using the health system as part of their immigration service rather than as a means of providing healthcare. And if that's the case, it makes it very difficult to then put forward a policy which tries to improve access to these people when some of your ministers are doing everything possible to stop them having access. How do we incorporate health promotion into health systems, particularly where the financial incentives are misaligned? If we are paying health professionals to do things to people, to give them treatments, to give them diagnostic investigations, then what is the incentive to offer them advice, to support, to advocate for healthy public policies? There is none. How do we develop the capacity to implement and evaluate health promotion in member states where governments have not invested in developing that capacity in their research community? How do we make the case for investing in health promotion to make the case that if we have a healthier population, you will save money in your health system? I want to move on to the next bit, which is looking at impact. Now, we have had 6 years of the expert panels. We have just concluded our second mandate. But the problem is that getting evidence into policy takes a long time. Now, André Riche did mention earlier that some of the work of the panel has already made its way into some of the European Union's policies, but we have to recognise that that can take time. We have public hearings to ensure that our opinions are grounded in reality, because it would make no sense for us to have academic reports that are completely divorced from the reality that all of you face. And then we talk about, I want to continue that by talking about setting the EU agenda. And these are the examples that we have. We have developed frameworks that are being used and being picked up within the European Commission, where we're developing a shared understanding of the policy questions. But I think probably, given that we haven't been going for that long, probably the major contribution is to clarify the concepts and the terminology. Often we talk about the United Kingdom and America being two countries divided by a common language, but often we need to recognise that we use the same words, but we have quite different meanings because we superimpose meanings on those words that are based on our own context and our own framework. So to summarise the challenges that we face, we're working with very limited evidence. Most of the research is from a small number of countries in Europe or in North America. And as George pointed out earlier, the United States is different, very different. In writing our recommendations, what are the policy levers to turn our evidence into action? How do we actually produce guidance which will really have an impact? Who are our audiences? Who can make things happen? Who has... In systems theory, we talk about ownership, the ownership of the system. Who has control over the levers of power? And how do we develop recommendations that refer and apply to very different health systems? So I hope that has given you a bit of an overview of the way in which we've been using those particular opinions, the challenges that we've faced, the strategies that we've used to try to overcome them. And with that, I'll pass on to our discussants, and then later on today, you'll be hearing about some of our other work. Thank you very much.
Okay, thank you, Martin. We'll now move on with the other presenters. So the first speaker on the feedback side is going to be Dr. Liisa Maria Voipio-Pulkki from the Finnish Ministry of Social Affairs and Health. Please, over to you.
Thank you, Mr. Chair. Brilliant talk, Martin. And I didn't talk to you about my intervention beforehand, but many of the ideas that you brought forward actually are on my list. Okay, but here we go. Yeah, I agree that from Finland, talking about health systems research, we have a lot of that type of activity, but we don't publish in English. So it's invisible, and that we need to work on. I'm here sitting as a representative of the Ministry of Social Affairs and Health. And my first sort of impression while I was listening to you was that what is policy making all about? It's about moving from questions to answers and action, even if they might not be perfect. But that's the type of situation where we are. We that are civil servants advising our ministers. They come and go and we stay. Well, in any case, what about the impact of this panel and its publications from my point of view? And I thought that I will be entirely honest with you and say that not much so far. And it's probably our fault. But I'm going to discuss a little bit why the issue is like this. You know, healthcare is not considered to be the core business of the European Union. And so, naturally, politicians look for advice from someplace else than the Commission when it comes to healthcare issues. So, a little bit it has to do with the language and sort of misunderstanding of the purpose of the panel. And on the other hand, I, for example, took a look upon refreshing my memory on the fact sheet on access in primary care and so on. Many of the recommendations and the indicators are not those ones that we actually do discuss in Finland these days. Some are, but not all. So the countries really are in different positions, as you already mentioned. And so perhaps when you start choosing for the items for the next panel, think about the needs of the, forgive me my phrasing, the more mature universal health systems, because also they are facing frog leaps, but they are different from those countries that still struggle with other problems. They are different. For example, when this access to care, you showed some of the items that I didn't see. For example, digital divide, which is one of those issues that we think that is a burning issue for us right now. So there is no question about the relevance of the issues that you have addressed so far. My next sort of iteration is the role of evidence in policy making. We already heard about policy making being struggling with headwinds. These are complex issues, and actually evidence is only one factor that feeds into the process. And academics don't always understand that there are many other aspects that we as policymakers, even like me who comes from the academic medical community, we have to accept that evidence is not just one of the factors that we have to take into account, even when we make recommendations to the politicians. And this brings me to the question of the target audience of your reports. Most of them are more than 100 pages, which means that only academic people can have time and the appetite to read them. When we write for ministers, the rule of thumb is that they don't turn the page. So I was really pleased to see these fact sheets, which I hadn't really found so far. So invest in dissemination and actively look for the response for the target audience that you actually wanted to reach. And then I started thinking about, when I read a little bit about the history of this panel, was that there was quite a tough discussion in the Working Party for Public Civil Servants, for senior civil servants in public health, WPP-HSL. Perhaps that is one of the groups where we should discuss the role of the panel again and bring it to the focus and the limelight of these people who usually these days again represent senior civil servants from member state ministries and organizations. Then, if I still have a couple of minutes, thinking about the future, the next panel, which is about to be nominated, I guess. Being the EU presidency, Council presidency country right now, and having had the Council conclusions on the economy of well-being accepted just a couple of weeks ago, I would really invite you to take a look upon the invites section in those Council conclusions. So the health systems really, so I'm trying to say that go a little bit beyond the usual phrasing, the usual issues, because we have a whole lot of evidence of that. But what about horizon scanning? What are the challenges of the health systems in the next 10, 15, 20 years? We have been talking to our Ministry of Finance more than we ever did during the preparation of these Council conclusions. And what they tell me is that you have the burden of providing evidence for that investing in people, investing in our health systems is worthwhile, and the return of investment is at least as good as it would be if I put the same amount of money, say, in traffic infrastructure. So this is the type of evidence that we are really looking for in the next few years. And finally, I came to think about the specific role of this panel. I think the strength is that it's not necessarily academic in the strict sense, but it also brings together sort of the intuitive feelings of these top experts who have a wide background about what would be the right decision right now. There might be insufficient evidence, but enough that you might be brave enough to give your recommendations. Horizon scanning I already mentioned. And I would like to also point to the emerging European health data space. What is it all about? What do we need it for? And how can we make the best out of it? So think beyond the conventional borders of healthcare and involve not the usual suspects, also from the academic circles, because we need multidisciplinary approaches and different paradigms. And finally, coming from a Nordic country, I have to say, pay attention to the gender balance in the panel. Thank you.
Many thanks for this open comments and the constructive criticism. That's what we are looking for. So now pass the word to the next speaker, which is who is Dr. Caroline Verlinde, who from the Finnish Institute for Primary Care.
Flemish Institute for Primary Care.
Flemish, sorry.
Yeah, thank you. I'm mainly going to give input from a policy level because I actually recently only changed jobs. Recently in Flanders we had a huge reform in primary care, and one of the institutes we've put into place is the Flemish Institute or Flemish Expertise Centre for Primary Care. And I'm going to get to that in a minute just to illustrate some of the impacts that opinions can have. Although I do agree with the colleague next to me that actually the direct impact of opinions is not huge, in the sense that I also didn't know about your publications. We don't refer to them when we make documents and we want to underpin them with scientific evidence, but I do think that your opinions have an indirect effect on our policy, in the sense that we were perhaps lucky, I don't know, but it might be a recommendation to have, it was actually the president of your board, of the panel, into our community in Flanders. Jan de Mazeneer it sits in different boards in different advisory boards in Flanders. So he actually introduced the key messages of what is in your different opinion documents, not even by referring to them, but just knowing them, he put them into our policy. And so I'm just actually realizing this as I read your opinion documents for the first time, because I needed to be here, that actually lots of things which were in there, we know about it, we knew about it, because they were also, for example, illustrated by our own strategic board of the Flemish Ministry of Health. But even to illustrate again, we sometimes refer to our own strategic boards and their recommendations, but we don't always do. But having the people knowing what has been illustrated or documented by our strategic board and bringing that into conversations and into policy making makes that what is published is not actually known by us, but is introduced via an indirect way. And just to, I find the discussion very interesting just this morning as well, that it's very different looking at papers from the context you're coming from. If you're coming from academia, you're looking at a paper from in a certain way. If you're working in the field, you look at a paper in a certain way. And if you're a policymaker, you look at a paper in another way. And I was just saying we had a huge reform in primary care, and the way we went about it is that we had 6 working groups from people on the field telling policy what they wanted to change within primary care. Then we also had a scientific board reflecting on what these 6 working groups from people on the field said that we should do. And so we also challenged the scientific board in the way that we put stakeholders from very different angles, because primary care is a very broad area and lots of professionals are involved. So a huge range of scientific people from different backgrounds were put into, let's say, a chamber, and they had to reflect on these documents, and they had to actually provide very quickly a consensus amongst themselves about what they thought of what we should take into policy or not. Because that's also a difficulty in policy making, is that you need to make quite quick decisions. And so the data and the policy and the scientific evidence needs to be in place there and then. And so I was a bit, it was on the last line that the data needs to be in place on the time that you need the data. In policy making, that's often happens that you don't actually have the exact data that you need on the time you need it. There might be data, but it might not be the exact data that you need. And then on the other hand, there might be scientific data, for example, on vaccines, saying, yes, this vaccine is evidence-based, it has an effect, and it is good to give it to the population which is in need. But then on the policy level, you make the balance, is this where we want to put our money into? And which is also interesting in the Flemish government is that all the ministers, they decide together as a group whether they want to take forward a decision or not. And this is actually a little bit, it's a first step to actually making health in all policies work, because each minister had to decide whether the decisions taken by the Minister of Health were actually a good decision. And so that's a first step, I think, and it isn't easy at all, because you have to defend, as a Minister of Health, your decisions to your other colleagues who actually want to put money into economics, into work, into education, etc. So it's interesting discussions, sometimes often difficult discussions, but if you're trying to convince your colleagues that health in all policies is also their responsibility, then sometimes it makes it a little bit more easy. And so the recommendation for the expert panel, I would say if you can make sure that you have stakeholders within the administration of each region or country within your panel or in a side group to your panel, so that they're actually quickly informed about what has been produced by the panel, and they can then actually introduce that into their administration and their policy making, would be one of my recommendations. And another thing I've learned by being in policy making is that it's often interesting, and also sitting here and hearing about different countries, it's interesting to see how other countries go about it. And a panel like this can actually trigger a different view, but then we also saw that you actually need to go to that country and experience and be able to ask your specific questions as another region or another country to know how you can go about it in your own region and your own country, because each context is different indeed, and you won't be able to copy-paste it, but you can learn from other regions.
Many thanks again for these very important insights. So we're now going to move to the feedback from stakeholders. So we're going to start with Caroline Costons, who is director of EuroHealthNet.
Thanks a lot, and thanks a lot for the opportunity to speak here. I would very much like to congratulate the expert panel on producing so many opinions, 11 opinions in 6 years. It's a huge amount of work, and at EuroHealthNet, 18 even. Oh, I counted 11, 18, even more. I particularly appreciated the opinion on access to health services, but also the one on health promoting health systems. There are very good recommendations there that we can certainly take forward in our work. At EuroHealthNet, we very much value evidence-informed policymaking. EuroHealthNet consists of mainly national public health institutes, and they all are trusted advisors to their governments. They give independent advice based on their own evidence. And so at EuroHealthNet, we also very value the evidence into the policymaking, and we always ask our members for input into the policy consultations. Because here in Brussels, we provide responses to the inception impact assessments from the Commission, to policy consultations, to policy processes like the European semester, and also to expert panel work like this one. But there's another expert panel like the Scientific Panel for Health, which is a panel for DG Research led by Professor Karen Sipido. They are slightly biomedical focused, so it's important to be there and to give our input. In our responses, we always take a health equity lens, because we always know that there are groups being left behind, which was clearly set out by Martin. And we highlight very much prevention and promotion. So in my suggestion now, how to further use the evidence, I would like to make 3 points, and I will be using a lot of words with peace. It is shifting the paradigms for prevention. It is the people that we should reach, the packaging of the information, the planning, and the timing of presenting the evidence. So firstly, on prevention. That is really vital if you want to reduce health inequalities. We know from evidence, and also from a latest report from the WHO on their health equity status report, that health inequalities are only explained for about 10% by health systems. and for about 40% by social security and social protection, and about 30% by living conditions. So prevention and addressing the underlying causes of diseases and the social determinants of health are really crucial and is often undervalued and overlooked in a way in a lot of the work around health systems. And this information needs also to come at the desks of the macroeconomic policymakers. It's the European semester very much, and also the European Pillar of Social Rights that are key for the reforms and the changing of reforms in member states. It's linked to the European budgets. It's also linked to capacity building, and it's important that we are systematically engaged in these processes at this level in order to feed in this kind of information. Secondly, it is, as has been said before, it is important to also look at the potential uses of the evidence. The opinions they offer, they are sort of complex, and it's a multifaceted areas that they are being covered. And it has been said before, I mean, you are producing fact sheets, but fact sheets alone is not enough. You really have to unpackage the complexity and contextualize them, because in every country the priorities are different, the practices and the policies are different, and if you can make targeted recommendations, then you'll have more chance on success. And in these recommendations, you need to really look at, okay, who is accountable, who is responsible, what can the European Union do, what can the member states do, and what about the stakeholders, the range of stakeholders in the localities, in the communities where we have the various services. If the evidence is well packaged and is pointing to the right solutions, then I'm sure we can persuade people to take it up. It also requires a lot of personal involvement. It is knowing the people and the networking. It's only with the packaging you are not there. So this means that we need to have people with various backgrounds involved. I hope that evidence will be collected in the future from a wide range of sources and from blending professionals, not only multidisciplinary academics, but also professionals like policy analysts or communication experts, or representatives from various civil society organizations, and all the stakeholders are key, because only then you are able to bridge the evidence with the realities, with what is happening in the policy field, what are the legislative opportunities, the funding opportunities, and so on. It's also crucial to constantly communicate evidence to the wider public. Now more than ever, in order to combat the fake news, the public needs to get constant amount of credible information, evidence-based information, and only in that way, information, can be useful and usable and used. My final point is the planning and the timing, which is crucial. So the evidence ideally should make recommendations for the short term, what's urgently needed now for the medium term and for the long term. So in terms of the short term, I mean, the European Commission always have their annual work programs, and they need to be based on evidence. For the medium term, there are now negotiations about the long-term budget of the EU, the multi-financial framework, and here we need to advocate and we need the evidence. It's on the mission, the cancer mission, it's on vaccination, on AMR, and this is for the intermediate term. And on the long term, there are the challenges that we know on the economic and the environmental crisis, the migration, and also we need evidence now, but it is also through foresight analysis, which was mentioned earlier, that we need to plan ahead for the evidence in the long term. And that applies also for this paradigm shift that I really like to see from more cure and care to prevention and promotion, to have a vision with having health services local in communities, people-centered services, integrated health and social services, taking the social determinants into account, but also environmental health. And I wonder whether we have enough evidence now to break through the silo working, and also evidence that can combat the vested interest that there are still for keeping the same old systems as we have, because this kind of evidence and this sort of expert advice is crucial for the long-term strategy of the Commission, and also for reaching the SDGs, as was referred to. Thank you.
Thank you very much for this intervention. We are now moving towards my left. We have ordered ourselves unintentionally in the right way. So we have now Michael Biliniak, President of the Pharmaceutical Group of the European Union. Over to you.
Oh, it's working. Good morning. I'm very happy to be with you here. And I will try to give you our perspective of the group of the stakeholder which represent the group which is now is trying and looking for a new way for themselves as a pharmacists and as a providers of the pharmacies. The being of the stakeholder is not a piece of cake now. When you are discussing with the politicians, they are always, I would say, quite distant from you, and are looking at you by the perspective of some interests, some business interests. So, especially when we've got some other stakeholders, when their interests are different from ours, and sometimes they are counter our interests, it is not very easy to provide ideas which we feel are good, especially as a group which is working with the patients directly, very close to them, and when we touch them every day. So when we are trying to give some ideas, some evidence, we are touching the problem of the tons of the evidence which are present. What we found in the internet, what we found in the public area, we find the thousands of the evidence which we don't recognize. We cannot recognize all of them, and in case of taking the decision, our politicians, policymakers, are always looking for some kind of different bottom of the discussion. So absolutely we are looking at on expert panel as a group of independent experts which give us some kind of guidelines, some kind of is shifting us the good way to provide and to follow those instructions, follow those informations which you gather, especially that we all know as umbrella organizations that, as was told before here, that it is very not easy to provide a copy-paste solution. It is not very easy to provide solutions which will work in the half of countries, and provide solutions which will work everywhere is almost impossible. So that is why that from our point of view, the expert panel is so important. We find that group of scientists, the professionals, former or involved yet in the profession, is so important to give the policy makers proper understanding of the situation where we are. Our case is very special because now, as I told you before, we are looking for some new kind of areas where we can support patients. We are trying to be patient-focused, and even today there was a discussion about an example of the vaccinations, and we are absolutely looking for all documents, all opinions of the expert panel, and we are looking for some new information when we as a professional can find our way to support patients with the understanding of the how members are differ from each other, how healthcare system differs, because beside of economic situation, because of the different situation of the patients, we've got very different healthcare system, and that's why we truly believe that this is so important to get evidence. As a pharmacist, we absolutely truly believe in evidence. But from the second point, it is very important to show the as wide as possible perspective for the policymakers. Of course, there is a huge question about how the voice of the expert panel is heard, how it is used, if it is well recognized. Maybe not in Brussels, but in the countries when we are trying to use those evidence, when we are providing some guidelines like the position papers or the vision papers. We truly believe that the growing of the role of the expert panel is absolutely crucial. It's absolutely crucial for us as a healthcare professional when we are speaking about the evidences, having some independent group which is trusted, which is working on very wide areas, which is giving a number of evidence is very important to help us to provide and build our role in the system. So this is absolutely our insight in the works, and we truly believe and we hope that the role of the expert panel will grow and will be able to use as in the past. I must tell you that we are very carefully reading all the documents, all opinions we are sharing with our members, and those opinions are very well recognized and are very helpful for us to provide us our ideas how to perform, how to build the future of our profession. So absolutely, we are keeping fingers crossed for you, and we hope that we will do as good as still today. So thank you.
Many thanks. Okay, we have two more presentations. So we now have Usman Khan, Executive Director of the European Patient Forum.
Thanks, Luigi, and good morning, everyone. I'm in an interesting position because I've been in post now at the European Patients Forum. It's 6 months and 1 week, not that I'm counting precisely, but 6 months and 1 week, and the involvement of EPF in the panel has been significant, and that's been led by Nicola Beddington. And I'd like to sort of note that and congratulate her for her involvement, as well as the Secretariat and other members of EPF. I have to say, in those 6 months, I've sort of reflected as to what the job of EPF as part of the wider patient movement is. And it feels like we are trying to create a patient-centered care is trying to make a pyramid out of pebbles. And for me, and I went back through the paperwork and went back through the comments and contributions that the EPF had made to the panel and panel recommendations, and I was judging it to say, what type of pebble does it seem? Because as a patient organisation, we're involved in a lot of these sort of activities. And I think that there was a lot of strengths. I think the fact that the patient perspective was considered, that in terms of involving EPF, there was a level in which the patient's voice was incorporated. But I would say behind that there are further challenges, and I think if we're looking forward as well as looking back, I think we can continue to do work around dissemination of the findings. As we look forward, I'd certainly concur with Caroline in terms of what we can do on orientation. I would certainly say that for EPF, we would always say that access is a key issue for us to be able to ensure that all patients are able to access affordable health care. But of course, we're recognizing that our pyramid is different. It's not about the old paternalistic model. And Caroline was talking about issues in terms of being able to have a much more preventative model, absolutely. And what we would also say is that patient-centric care is fundamentally different. And this isn't just about adding aspects of patient engagement to the old traditional model that was so well encapsulated to me. I know I say this in a lot of settings, so apologies if I do. But when I heard a friend talking about an engagement with a doctor, and the doctor said, when talking about a knee replacement, my advice is to take my advice. And there was something pretty profound about that was both very reassuring about what healthcare was about, but also everything that was wrong about the paternalistic model. And we know that what we are doing in moving away from that, my advice is to take my advice, to the Eric Topol idea of the patient will see you now, it's a fundamental reorientation. And if we're going to do that, and if we're going to look at what we can do with the next aspect of the panel, it would be to say, how do we look at the orientation of it to make sure that it's fundamentally orientated towards patient-centric care? How do we engage, yes, EPF, but also how do we engage the wider patient community meaningfully? And how do we support that engagement? Because another thing that's very noticeable to me in my first 6 months is there is an enormous amount of goodwill from the patient community to be able to be involved, but have no doubt that what they are willing to do and able to do in terms of sharing a lived experience for the betterment of healthcare, and quite often giving up their own time that with no resources or little resources, that we need to think about what it will take if we really do want that new pyramid to be built. And then the final part would be dissemination. And I would agree with dissemination. I think having these all the way, I think we do need the detail. And you know, the fact that that commitment to the evidence base is hugely important. I will put it in brackets to say that we do need to recognize a lot of that evidence base is still on the old traditional paternalistic model. And we need to incorporate the new patient-centered evidence as that's coming out, and that is coming out, and we have been able to involve it. And then finally on dissemination, to say, let's think smartly about dissemination. I do feel, and having worked in Brussels and loved working in Brussels, and really feel the benefits of what we're able to do in terms of health system improvement, that sometimes we are a little bit like the World War II plane throwing leaflets out of the window from a great height, and that we should really try and think as smartly as possible about how we can use different platforms, social media, other ways to be able to engage with the patient community as well as with wider member states. I'll leave it there.
Thank you very much. So that was the patient perspective, a very important one. So now we have covered the stakeholders. We have a last intervention from John Ryan from the European Commission, DG Santé. Over to you.
Yes, good morning, everybody. And I was impressed earlier on when Pavel spoke about the fact that the EU is a temple of evidence, and a temple of evidence-based policy, I think he said. I'm going to write that down because I think it's something I'd like to use again. But in fact, on a daily basis, just to give you an idea of the sort of groups with which I interact on a daily basis as Director for Public Health in the Commission, we have the scientific committees, which you heard about earlier on, for consumer safety, but we also have a committee on health, environment and emerging risks, which are consulted as well on issues like fracking, for example, or 5G. So these are groups with which I interact on a regular basis, but also we have other Commission departments, as you've seen, who produce evidence and reports on different topics, plus the agencies, the scientific agencies of the European Union, 300, 400, 500, 600, 700 people working to focus on a specific area. The European Centre for Disease Prevention and Control, EFSA, the Food Safety Authority, the Medicines Agency, and so on and so forth. I mean, all of these agencies are producing large quantities of evidence, and I've heard this discussion before about how they synthesize their advice in a way that's accessible to policymakers in whatever area they happen to be responsible for. So the issues you've been talking about accessibility of the evidence and presenting the evidence in a synthetic way that's accessible to policymakers is something which we're familiar with, because it's something which all of our agencies and all of our departments are trying to deal with on a regular basis. Not alone, we have our own agencies, our own commission departments, our own committees, including this one, but we also have, of course, the advice coming to us regularly from WHO, which has its own standing. And it's very important, of course, to make sure that the advice which we get from WHO corresponds to the advice we get from our agencies. And we've seen, I'm not going to start quoting examples to you, but we've seen some very controversial slight differences of approach or appreciation between our regulatory agencies and the WHO or its agencies in the evaluation of the risk, particularly of particular products. So this is the sort of daily business which we have, but we also have other sources of advice for policy making in the European Union on health. And I'd quote in particular a recent example which really struck me as good practice. And it's not because I have a Finnish colleague on the front table here that I'm going to quote the Wellbeing Council conclusions. The Finnish actually started things right. What they did was they asked the OECD to prepare a report. And the OECD prepared a report in time for the discussions within the presidency conference and then the adoption of the conclusions. So if you're really looking for a very good closed circle of how to make a policy, that was a good example, I think, of where the report came just at the right time. It was commissioned specially for that piece of work. But that doesn't often happen in reality because very often you're trying to run after an event rather than having sufficient time to prepare for it in advance. Now, that's the point was made earlier on as well about scientific advice and this should be the basis of policy making. Well, that's again wishful thinking because you can have the strongest scientific advice on a topic, but the question is, do people believe that scientific advice? And the credibility of citizens, of science among citizens is really a big issue at the moment. People don't believe what you tell them. So we have issues, for example, I just quote the example of vaccination where huge controversies about the necessity for vaccination. Why should I be vaccinated against a disease which is not a threat to my child? You know, and all these false rumors that are spreading on social media. So this was an issue which really, you know, we see the effects of this in daily business because of outbreaks of vaccine-preventable diseases. But that's not the only example. Another example, and I'm probably exposing myself to 5G at the moment by holding this thing, but the risk evaluation of new technologies, including 5G, is a major challenge as well. So people don't necessarily believe the studies that are there. They think because they read something somewhere that there must be a risk, and therefore this is holding back as well the development of new technologies which can be very beneficial for society. And a third example is, of course, the debate around GMOs and pesticides, where you can have all the evidence you want, but you know, transforming that evidence into policy making and dealing with the fears of people is really a problem which policymakers have to make. So you can have the evidence on one side, but actually translating it into something concrete, into legislation or policies, is really not as easy as just transferring, copying and pasting something from one of your reports into legislation. That's not how it works, as you know. So this is, but I think it's really important to have the solid evidence base. And that's where the committee like yours can play a role, because you can digest, you can synthesize, you can present the evidence, you can update the evidence, because sometimes the evidence is not recent. So it's good to bring it up to date and to present the latest arguments, and also to review what the experience has been in implementing the evidence somewhere else. So you can look at the case studies, you can try and synthesize what is the best way forward. I think there is a pressure on governments in general, but also on the European Union, to be efficient and effective. So that's why it's important to have good evidence base, so that you can actually back up in your better regulation approach, you can back up what you're proposing by solid evidence. And of course, I'm not saying that there is not a specific national context in health, far from that. Everybody who's spoken so far has spoken about the national context. But you can't tell me that there are 28 different solutions to one problem. So if you have a problem with vaccination or diabetes or HIV or environmental diseases, respiratory diseases, You can't tell me that each country will have 28 separate replies. So you can talk about context, certainly, but please remember that we're not so strange a continent that we have to have 28 different solutions. And I think there's a lot of value added to having common approaches, or at least to comparing the approaches between countries, because then we can also see which is the best approach to take in a particular context. Now, something Martin said caught my ear as well, the issue of the SDGs, the Sustainable Development Goals. The Commission has signed up to these, plus all the member states. And I think it's really important that we have these common objectives. And we also have the WHO disease-specific targets, which we shouldn't forget. So really, we are working from the same hymn sheet. And I think it's important that we recall that as part of our, to have a target, a common target together in health is really important. So, of course, a report which is coming from a scientific committee automatically gets a reaction. Some people will be happy, some people will not be happy. And that's why it's important that when you present your evidence, you try and bear in mind the need for a wide consultation so that you're at least aware that some people may be opposed. I'll give you a very good example, and a recent example is the issue of sugar. So sugar tax, nutrition policy, obesity, childhood obesity and so on. When you look around for evidence to actually underpin policies on sugar, you find yourself in very deep water very quickly. So that's an example, maybe not for your group, but where we're trying to find our way. And I can see Martin already, sort of pointing me towards studies. Well, there are lots of studies, but the industry will come up with other ones. So that's why it's important to know where you are situated on the map. Now, I just take one or two words on the impact of the different opinions. And the opinion on improving access to treatments and unmet medical needs was followed up in a member state project involving countries building up a database on national prices and pricing regulations for medicinal products. So the ideas which were contained in your opinion actually found their way into a member state project. The Council conclusions under the Dutch presidency from June 2016, so quite recently, also acknowledged the work which had been done by our group. The WHO technical report on the pricing of cancer medicines and the resolution of the World Health Assembly on transparency of pharmaceutical markets also took account of your work. So I just wanted to quote that example as being probably a good example of where the reflections, the ideas you came up with in your report were translated at the Council level into projects with the Member States and at the international level through the WHO and the World Health Assembly. In terms of the work you've done on access to healthcare and the opinion which you gave there, I mean, this has come in different ways. You developed ideas on problems and policy responses, on assessing accessibility, also on methodology for benchmarking access. And these ideas were taken up by the Commission in a pilot project which was funded by the European Parliament, but also we used this work in our analysis of the state of health in the Member States. And I can talk here for a moment about the future rather than the past, because we hope to be able to use your work as well in the development of the Europe Against Cancer, the Fighting Cancer project, which is one of the key projects in health of the new Commission. And clearly access to medicine, access to prevention in cancer is an extremely important topic. So I guess that, if we're clever, we will look for the evidence also using the material that you've produced. You were talking earlier on about vaccination, and clearly it's a key public health measure. There are a lot of difficulties around vaccination at the moment. The ideas which you came up with in your analysis of vaccination were actually used very practically in the work which we did at WHO and the Vaccination Summit and the Council conclusions which were adopted on vaccination. So, if you like, we have tried to incorporate the evidence that you gave us in policy making in a very practical way. And the last point I would make is in relation to the importance of engaging with other groups and using our financial instruments. We have attached importance to the links with the member states, and we've created a specific group now for looking at the implementation of measures in public health to reach the Sustainable Development Goals and the WHO targets. And the type of evidence which you're producing should be part of that circuit. I'll leave it with that, and I'd be very happy to come back later. Thank you.
Many thanks for this insightful intervention. We were supposed to have like a second round, but I think I'm going to wait and open up for questions from the floor because we're running a little bit late, and then come back to the panel. So is anyone willing to ask a question?
Yeah, Luigi, I'd just like to say something. Evidence. We haven't really defined evidence, and people have talked about scientific evidence. Preceding evidence, there is a question. And one of the important things is to define the question, and then you can look for evidence. And when I teach my postgraduate students, I say one question at a time, otherwise you will get into a mess. And then you can amalgamate all of these answers together. So before evidence, we need a defined question. We then need to collate that evidence in the context and so on. But then we need to look at risk. And your concept of assessing risk is very, very important. So those three things together are the important things. And then in the middle of that, when evidence is obtained, you have to say, what is the veracity of this evidence? Is it hard? Is it soft? And then make a judgment on that. So judgment is the next thing. So we have the question, the evidence, the judgment of that evidence, and then the risk as the components. And Claude Bernard, a great physiologist, years ago said, if you wander without a preconceived idea, you get nowhere. If you've got a preconceived idea, you can test that. And that's really what we should be doing. Now, sometimes there is no evidence. And what do we do then? We make decisions on experience, we make decisions on intuition, and we hope they're the best ones. As a clinician, when I see somebody who's severely ill with sepsis, I have to say, goodness me, what antibiotic do I need to give here? What's the best bet to help this patient? And that's based on a range of evidence, but it's also based on experience. So all of these things come together. But I'll finish now, I don't want to take too long. But the important thing is, what is the question? And then work through from that.
Well, I'd like to pick on that up, saying, like, please, can you formulate like a question for one of the panelists, and maybe try to flag to whom you would like to address that question. So, is there any other questions from the floor? Yeah.
Hello. I have a particular question to Dr. Verlinde. So you shortly mentioned the health in all policies, and as far as I understand, in the Flemish government, the health ministries should convince the other ministers like transport, education, and finance. So it is. I'm very glad to hear that the health and all policies can be realized by this way, but it shouldn't be a one-way street in my side of view. So also the Ministry of Finance or Education should also convince the Ministry of Health.
That's how it works.
Does it take place?
Yeah.
Okay,
yeah.
so
yeah.
just to...
But I mean, I was just thinking this is a very, very minor step into health in all policies. I mean, because it's actually just convincing your colleagues that what you're doing is the right thing, and they need to be convinced that it's right. And if it's not, then you go into debate, and you might change your policy a bit so that everybody agrees. So is it health in all policies? I call it like that, but we have seen that making decisions in that way makes the other ministers more aware about the other politics, and health is one of them, that they can also have an effect on that. But it's a very small step only. Yeah.
Any other questions? Yeah, down there.
Hi. Yeah, I had a question maybe for Martin or maybe for more panelists, but about specifically around vaccination. I was wondering, do you have any reflections on how to engage specifically with the anti-vaxxer movement without, in a way, legitimizing their concerns? And I'm asking this because I recently read that the European Parliament has told the EMA to carry out another study into the safety of vaccination. And my concern is just that that sort of legitimizes that movement and kind of puts the two on an equal playing field. So I was wondering if you had any thoughts about that.
Sure. Well, I think we'll be hearing more about that actually this afternoon in one of the speakers this afternoon. But we just to pick up, it links to some of the things that were said earlier. But I will answer that in a minute. But I want to pick up on the other two questions, because clearly we spent a lot of time trying to work out whether we've got an answerable question in all of this. It's not just enough to have a question, but it has to be a question which is capable of being answered. And to link what George was saying to what you're saying, yes, it's all very well, how do we make decisions when we don't have adequate evidence? But also we're very conscious, and we said a lot in the report on vaccination, on the role of cognitive biases, because we know that people make decisions often incorrectly because of their preconceived notions. You know, we have clear evidence that just educating people, giving them critical appraisal skills doesn't always work. The classic study that Kahneman did, which looked at asking people to do a mathematical exercise which with the same figures, which was either about skin cream, which was not controversial, or gun control, which was, and showed that mathematical ability was relevant in answering the question when it's framed as skin control, but your attitude to gun control was overwhelmingly more important in that question. And then the World Bank did it among their staff, all of whom can count and have a high level of mathematical ability, and did it with skin cream versus minimum wages. And they found exactly the same thing. So I think in all of our work, we're conscious of the way in which information can be misinterpreted, the way in which cognitive biases filter the information that we have. And so it does link, I think, to both. But particularly with anti-vaccines, we do say quite a bit about this. There are many, many reasons why people promote anti-vaccine messages, and the paper in AJPH a little while back divided them into, I think, 3 groups. One were the people who genuinely have concerns about vaccine safety, even if it is irrational. And they may have had a child who's had autism or some condition, and they in their head they link it to that. That's one group. Then there are, of course, the people who are promoting messages because of clickbait, which is essentially directing you to websites where they can earn money from advertising or to distribute malware, and that's the second group. And third, there is state-sponsored messaging, which is both promoting pro and anti-vaccine messaging coming from one particular state, in the same way that they promote both Black Lives Matter and white supremacy in the United States. So all of those 3, there are different solutions to each of them, but I think that may be picked up later, so maybe I shouldn't say too much about that.
Thank you.
Yes, thank you. I would like to sort of continue from that question about the question. So as an ex-intensivist, I perfectly recognize the situation that you described about the patient with the sepsis and the clinical judgment there. But in my present role, I see it a little bit differently. Who has the right to phrase the question? If we have a certain process ongoing in our health and social system, in the society, so the question that I can make as a civil servant with a medical background can be quite different from the question that my minister make. I mean, he or she sees a different sort of side of that phenomenon or problem or process. So the question is that sometimes the questions come from top down, sometimes they come bottom up from the professions. And so we, civil servants in the ministries or public health institutions, sit somewhere in between. And my sort of, I wish that the panel, the next panel, would try to do a scanning exercise that what kind of questions are we going to face? They can be quite surprising.
Can I? Oh, sorry.
Sorry, it's just a sort of, I think this is a really interesting discussion, because this idea of how do you frame the question and how important that is. And I think when we're talking about wanting patient-centred healthcare, then I have to say, you might say, well, of course I would, but I have to say that it's not just how you frame the question, but who do you ask that question to first? And I think there is a sequencing issue here. And if you look at the issue of vaccines hesitancy, when you talk to patients, you really do start understanding, as Martin was talking about, that sort of nuancing of that. You get further nuancing that really does help you to unlock what might look like a wicked problem becomes a much more manageable problem if you engage patients systematically in both framing as well as answering the question.
Okay, please.
Yes, I would like to add that where the question comes from, and we have so many questions related to health and other policy areas. So will an expert panel with mainly health background and expertise be able to address these questions? So one key question that we currently have at EuroHealthNet is, where is the money coming from? And we know there are huge underinvestments and huge gaps in investment in health services since the crisis. And also we know the demands have been increasing due to aging, due to the increase in non-communicable diseases. So we need more money. And how can we do that in a smart ways and in innovative ways? So looking at impact investments. There's a huge amount of banks out there that are interested to invest in interventions and projects with social impacts, with health impacts. And what sort of criteria can we give them so that we know, that we are sure that the investments are actually contributing to health and well-being? And that's what I like so much of the economy of well-being of the Finnish presidency. I mean, how can we make sure that the finance people understand the positive health concepts, and what sort of evidence do we need? I know it's all the health economics and so on, but how can we convince the investors and the banks, and how can we get to the finance table, and how are we going to address these kind of questions in an expert panel? Because clearly you need to engage with a whole lot of other experts and people that are probably beyond your own expert panel.
Okay, thank you. So let me check if there are some other questions from the floor. Sorry, Maria, I know you want to come back, but I'll ask you later to come back. Yeah.
Well, it's a short and follow-up question to that, because I'm curious to hear from the Commission and other stakeholders, following from your comment, in coming back to the experts, to the expert panel. Do you think this is a matter that the expert panel can do, or what type of help do they need? Because I imagine fiscal policy is not the usual topic. The people in the panel, even as interdisciplinary as they are, it's a little bit beyond. I would like to hear your views. Is this the role? Is this something that you expect the expert panels to do, or is this something for policy making? And you mentioned also consulting stakeholders, but is this something that really needs to be done by the expert panel, or should there be a separation?
I'll try to answer that. I think our remit is quite broad, so I think we have quite a broad array of skills that probably could go into those questions as well. So I don't think that we are precluded from going into fiscal issues, and I think we have already engaged in some of them. So perhaps there is one question over there. Yeah.
Yeah, Paul Barish from the U.S. Martin, you spoke about the issue of autonomy, and John, you challenged that. We haven't talked about physician autonomy, which is a particular challenge, and particularly my question to you is, we haven't talked about variation. And in all systems, going back 75 years, the only way to improve quality is to address variation. So how does that play in, the autonomy around variation? Martin, short question.
Yeah. Well, in Europe, wouldn't it be nice to know? And this is the difficulty, because in the US, you have all the federal data sets that I talked about, and you can actually look at that. We can't. So we don't have the comparable data with the comparable definitions. Although even in the US, to be honest, you are limited often to Medicare and the over 65. So there are other bits that you don't necessarily get. So I think that highlights one of the major constraints that we have. Obviously, we're all familiar with Jack Wenberg's work and all of that, and clearly that's there. But we totally buy into it, but we're constrained in what we can do. But can I just pick up very briefly, if I may? I hope I've sort of answered that in that, yes, we're aware of it, but there's a limit to what we can do in Europe until somebody collects all the data. But just to go back on this thing about, advisors advise and policymakers make policy. So we have to be clear about what our roles are. But within that, there's a hugely important issue that people picked up on framing. Because we always ask, why is this person asking us this question at this particular time? And to go back to John's point about GMOs, there are 3 ways in which you can frame the GMO debate. Is it about the safety of eating GMO crops or whatever? That's one question. Is it about biodiversity? Is it about intellectual property and human rights and things like that? Those are 3 quite different framings that come up with quite different answers. So you need to be clear what it is. And we're very conscious of things like, the Overton window that many of you are familiar with, which is the range of issues that are acceptable at any particular point in time, like the fact that none of us would actually accept that slavery is appropriate now or would be allowable. Everybody here would buy into the view, I hope, that women should have votes. 100 years ago, 200 years ago, that would not be the case. So our range of views, we need to, recognise that they're not actually fixed. And that comes into your point about, how do we get people to invest in health? Strangely enough, it is often the finance ministers that put forward the arguments about investing in health. The argument that is now being taken forward following the Tallinn conference in 2018, health, economic growth, but also better health for social cohesion, because they're realizing in the US and in the UK, areas that are having declining health are voting for populist policies and politicians. So social cohesion, economic growth, health has to feed in. And the pressure is coming from interior ministries, it's coming from the police. In some places, it's coming from finance ministries, and they are reframing it. And I think we have to accept, all of that, and we need to go with that. But we are acutely aware of unpacking questions and saying, what is the taken for granted in this question? What is the underlying assumption? And we spent a lot of time working that through in the panel. And we do bring together, I think, a very broad range. And, do we have the expertise? Do we have the skills? Well, maybe not in particular areas, but we have the ability to go and find the evidence and talk to the right people. And I think we recognise with due humility that we don't have all the answers, but there are other people who often do have, and we can learn from them.
Okay, so now I'm trying to wrap up. So first I want to make a small comment about the variations, which I think we are all very well aware as an expert panel, and I think there are several opinions where we discussed in quite a lot of details. And I think there has been also some work within Europe, and Sabina Nuti, she has done quite a lot of work in this area, in Italy, variations across regions within Italy. So I think that is pretty well covered in our opinions. Now, as a way to wrap up the discussion, I would actually like to ask final questions to each of the panelists, and to say, if you had one recommendations for the next panel, what would that recommendation be? I mean, that could be on coming up with new opinions, or addressing specific issues. I really found one of the first remarks important about the member states not necessarily always thinking for health policy as the EU as the focal point. So is there any recommendations or suggestions how we could fill that gap, and so that the next group can do that part a little bit better, so the dissemination to the member countries and making sure that they use this information more consistently? So I'll start from that.
Yes, thanks a lot. I would say for the next panel to take seriously the role of knowledge brokering. Don't assume that with having a fact sheet, even a fact sheet, you are done. It is really monitoring policies, knowing what are the windows of opportunity, knowing who has the powers and how to repackage the information so that it has any impact. The role of knowledge brokering is normally underestimated in terms of the time and resources it requires to do that.
I think we do need to be realistic about what a panel can do, because it is a panel, and the whole point about knowledge brokering, wearing another hat. I'm heavily involved in knowledge brokering, and as you say, it is intense, very labour intensive. And I think both John was saying through the Commission, the way in which the opinions do get out into other, they're maybe not recognised as such, and the example of Flanders and Jan taking the primary care work and unmet need out, I think in other ways helps. But I think the Commission does some things, we do some things, and it's not a knowledge brokering organisation, but we definitely can do. One thing we can do, I think, write shorter reports. We all would like to write shorter reports. And maybe, you know, to paraphrase Oscar Wilde, I have written you a long letter because I did not have time to write a short one.
Okay, thank you. Well, take a look upon the existing mechanisms, and I think that one that we haven't valued enough is the semester process. Yeah. The social pillar, economy of well-being, and very concrete terms, take a second look on the joint assessment framework.
Yes. Okay. I would say try to broaden your network. So you're an expert panel now with experts, but see how you can enlarge your effect by involving people next to you and make a certain learning network or network which you can involve in putting your recommendations into the countries and the right people and the right persons in the countries by broadening your network around you.
I would follow one of the questions about how to support the panel and how to use properly the outcome of your work, really, because your work is brilliant. And our thing is that in some cases, this is only some document on the web page which is not very easy to navigate. And the question is how to, from the first point, how to show it to the wider group of people, not only the decision makers, but the professionals, healthcare professionals, also to the Commission, maybe to the European semester, just to put proper context to the discussions. And to assure that, because it's absolutely your opinions are brilliant too, brilliant, absolutely. But what is very important, they must be treated as a absolutely high-level expert opinion, which will be not comparable with some, I would say, internet troll insights or information put it on the web pages. So from my point of view, this is something which is absolutely crucial. Absolutely, in the case we've got discussions like vaccinations, which are based on the emotions. We've got, sorry, I will just spread my answer to this question. But if you look on the vaccination discussion, you will find that everyone is interested to provide support to the vaccinations, to increase the level of the vaccination. But we are facing with the emotions, and there's the question how to provide proper marketing of your products, which are the opinions. How to show them in the same way how people are reading this fake information. How to assure that your work will be read properly and it will be treated as an absolutely first guideline which should be taken into consideration. And from my point of view, this is something which you should focus, because you may do huge work, but if it will be this PDF on the web page, it is not the case, which I would like to look on. So this is my recommendation, and PGO recommendation.
I totally concur on knowledge brokering, understand the audiences, the range of audiences and the way those audiences best respond to the evidence. And then I will say, and I've got to say, make patient perspective the first question, not the last question. And think about how patient voice can be meaningfully engaged and the challenges of ensuring that it is.
I just go back to one of the first points that was made, and this is the issue of how do you survey the available evidence? And if you're telling me that there are only 5 member states who are in the front line with evidence, then I think there's something wrong with your system. So looking through the English language publications may not be, I mean, maybe I'm...
We use Google Translate as
well. You use Google Translate as well. But I mean, it seems to me that there's a lot of evidence out there, and maybe different types of evidence which could be engaged. Thank you.
Okay, so thank you very much to the panelists, and thanks a lot for all these thoughts. I think that there are quite a lot of new ideas for the next mandate to develop and to take into account. So I think we're going to now break for lunch, and then we're going to come back for session 3, where we are going to use a similar format, but we're going to focus on a quite different set of issues under the broad area of measuring performance of health systems. Thank you very much.